everybody. My name is Yaron Berkowitz, and on behalf of the OCAD group, I just wanted to introduce our speaker today. So Dr. Matt Scarborough graduated from Queen's University in Belfast. His early postgraduate experience included medical education and refugee relief work in the Middle East. He returned to the UK to complete specialist training in London and Oxford before traveling to Malawi to work on bacterial meningitis. And he now works in Oxford, where he splits his time between clinical infection work, general medicine, and research. He's a consultant in infectious diseases at Oxford University Hospitals and is an active researcher and is affiliated with the Experimental Medicine Division of Oxford University with over 100 publications to his name. His current academic interests include the use of local antibiotics in bone and joint infection and potential infective etiology of back pain and the management of Staph aureus bacteremia. And he is one of the leads of the bone infection unit and multidisciplinary meeting for the region, which is how I've come to know him. So without further ado, I will let Dr. Scarborough take it away. Thank you very much.
Thank you, Yaron. Very kind of you to invite me. So the picture that we're looking at here is an aerial view of the city of Oxford. If you turn right out of this picture and go for a couple of miles up a hill, you'll come to another building. Let me just see. Yeah. So this is another building called the Nuffield Orthopaedic Centre. And in this little bubble over here, there's a specialist ward called the Bone Infection Unit. There's 26 beds on it, and we host patients with bone or joint infection. The ward is essentially run on a day-to-day basis by us physicians, but of course the patients are all surgical. We're quite keen to accept observerships in Oxford because we enjoy being seeded with new ideas and our old ideas challenged. So anyone who does want to come over, you're very welcome to at any time. You just need to write to us. There is quite a backlog at the moment, but please just feel free to come over or to at least write to us to invite a time. What have I got to do? There's three groups of people that most frequently populate our ward. Well, this is the first one and by far the most important. When I started, I did a quick poll on our ward as to how people were feeling, and a third of them were a bit cross because someone caused their problem. It was either the driver of the opposite car or the surgeon who did the past operation. The next third were annoyed with me and the surgeons I work with because as a profession, we weren't able to cure them. And this is often a really long-standing problem with disastrous outcomes in comparison to most other diseases that come. It's got a worse mortality rate than 4 of the most common cancers that we treat. And the third population on the ward were just cross because it is so disabling. The next group of people that are on the ward are our surgeons. So I asked the surgeons just to describe with one word what popped into their head when you say this is a bone infection unit. These weren't orthopedic surgeons. These were all types of surgeons, all trainees, and these are the sorts of things that they came up with. Nobody really wanted to embrace infection as their working home. So this unit was set up really specifically to do that, to make it our job, our raison d'etre, to work with infective cases. And I like to perpetuate the myth that the third group of people that are involved with the ward are the physicians, and although it's not really true, this is the sort of picture I like to paint for them. So that's really who's on the ward, and we work almost entirely in a multidisciplinary method. I have to persuade my colleagues that there is utility to an infection specialist, and if you look around in enough papers you can find proof for almost anything. But this is a nice paper that looked at the added advantage of an infection specialist, either from microbiology or from infectious diseases, and it's a study of 70 patients with quite marked osteomyelitis, either Cherney-Mader type 3, which is cavitatory osteomyelitis, or type 4, which is segmental. And if you just provide the surgeon with the microbiology results and say, call us if you need some help. The favorable outcomes they get from each of these is above 50% here and above 20% here, but overall about 42% of their patients do well. If you then say, I'm going to impose upon you an infection specialist, and you do as you're told, then it goes up to 90% in this group and 70% in this group. So overall a 78% success rate when you have a dedicated ID input. So that justifies me to a certain extent, and this has been replicated actually. I think this was from somewhere in South America, 109 patients. And again, they looked at various factors that might influence outcome. And the one factor of these that they chose, which included age, the bone that was affected, the cause of the osteomyelitis, either fracture or non-fracture related, and the duration of therapy, the only factor that came out as significant was whether you involved a treating specialist that was an infection specialist. If you, again, just left it for the orthopods to interpret the results, the outcome was much worse. So we feel fairly comfortable that we can convince our colleagues to make use of us, and we're quite proud of the relationship we have with them. Traditionally, at least in the United Kingdom, surgeons and physicians often don't talk to each other, but in particular, orthopedic surgeons and physicians don't talk to each other. But in truth, when you do look at it, actually the surgeons do by far the majority of the work with all of these tools and all of these things that they can do. And my job is essentially to choose the right drug at the right dose, administer it by the right route for the right duration. So I've got a very simple job compared to them, but everything that they do without me is jeopardized if there's infection remaining. And of course, everything that I do with my drug will probably get nowhere without the appropriate surgery. So we are really very dependent on each other. And this is the sort of case that, that we see in Oxford. You'll see that it screams out for a fairly large number of specialties. This was an open fracture. I think this guy was in Thailand at the time. He needed a gastroc flap at the time, so we clearly have to involve our plastic surgeons. There were some multi-drug resistant organisms, so an infection specialist, and of course there was quite a lot of radiology to interpret, and so we needed quite a lot of help from our musculoskeletal radiologist with the surgical planning. Then OT and physio were involved. The pharmacist had to get involved because of some antibiotics that we don't frequently use in this country. And we manage it all through our dedicated bone infection unit, and it's all multidisciplinary. The principle of the orthopedic surgery is that they can do it with absolutely no fear. They can make a hole as big as they need to remove the infected tissue, because they've got a plastic surgeon coming up behind to fill the gap, and they've got an infection doctor behind that to kill any remaining bugs. Of course, because the patient is right at the center of everything, all of our cases are individualized. So there isn't really a protocol for everybody, but there's certainly a sort of management pattern. This is what it looks like. We receive referrals from all over the country. It's usually on a dedicated pro forma, which they just download from the web, but we can take letters, emails, or phone calls. As soon as the referral comes, we chase up for an image transfer, and without images from their local hospital, hopefully in some sort of chronological order and relevant to the current condition, we can't easily proceed, because the next step is to do a triage, and it's always a triage by one of the consultants, either from ID or in orthopedics, or both, because this is really crucial to the final outcome of the patient. Every referral is triaged into direct advice, so I quite often will phone up a hospital and offer advice, particularly if I think that it's something that could be managed locally. About 2/3 of our referrals go into an MDT discussion, and that's where we sit down with our radiologists to work out exactly a plan of action. And most patients, either having come through the MDT discussion or directly come to the outpatient department for a double or a triple appointment. And that means they're going to be seen by orthopods and ID, or orthopods, plastics, and ID. And finally, we can, with very complicated cases, particularly those who are immobile or from a very long way away, we offer a 3-day assessment visit with repatriation. So they come over not for treatment, but just for assessment. And they can then be seen by the medics, the orthopods, the plastic surgeons, the anaesthetists, and anyone else who we think might be relevant to them, including our rehabilitation consultants, if that's appropriate. So that's how patients get to us. When they do arrive, these are the sort of patients that we think are most likely to benefit from coming to us. And we divide them up according to 4 domains, considering the amount of bone involved, the difficulty or not with the antimicrobial options that are available, the need for plastics, or the host status. So these spell BACH, B-A-C-H, and each one can be uncomplicated, complicated, or limited options. So if all of these, if you've got a simple cavitatory osteomyelitis or a Cherney-Mader type 2, which is just a surface cortical osteomyelitis, and no complicated bugs or antibiotics, and the soft tissues are pliable so you can close them, and the patient's well controlled or has no other comorbidities, they can probably be managed at their local hospital without the need to be taken far away from home. On the other hand, if anything is complicated, such as segmental osteomyelitis that needs a block excision of a length of bone, or if there's a complicated bug, or if you need a plastic surgeon, or if the host is of poor quality in some way or other, then they're likely to need referral, or likely to benefit from referral to a tertiary unit such as ours. Sadly, there are some that we don't take because they're either unfit for surgery or they don't want surgery, in which case there isn't really a lot of advantage in us seeing them. We do, of course, take patients with a very difficult microbiome to deal with, but it comes with a caveat that we may rely on suppressive therapy or some other form. So this is the sort of hub of our MDT, and every week we meet with the radiologists to go through every single case. These are patients either before they've arrived with us or after we've seen them at the outpatient clinic. And we sit and we develop a surgical and medical plan or further investigations, and we get that fed back to the referring clinician almost in real time. It goes just immediately after the meeting. We have a pro forma where we record everything and it goes sent off almost immediately after the meeting. The vast majority come through this meeting are actually invited then to our outpatient clinic. But by then, the 4 of us, the radiologists, the orthopods, the plastics, and the ID have got a fixed plan of what we think is appropriate to at least to start out with. I know this is going to annoy some people, but we are still pretty steam powered in Oxford, and we rely very heavily on plain films. They're still probably the most useful modality, at least on the ward for us and our day-to-day things, but we rely very heavily on our musculoskeletal colleagues, radiology colleagues for interpretation of the cross-sectional imaging. We tend to do very, very little nuclear medicine here, apart from PET scans, which are becoming increasingly used, but we do very little bone scintigraphy. And that's probably because we don't find that it adds sufficient value. It may be, that we don't have anyone who's passionate about it in our radiology department. I don't know, but we've never used it, even even when we've got a completely different staff complex in the radiology. The patient comes to the triple appointment in this case, where they are seen at the same time by the 3 different major clinical specialties. This is unbelievably reassuring for the patient because we're clearly speaking the same language and singing from the same hymn book. We're understanding what each other's issues are, and we can reassure the patients that they're not going to be sort of passed from pillar to post with no one accepting responsibility, because it is truly a shared understanding that we have. It doesn't actually save me any time because I've got to listen to Alex, our plastic surgeon, drone on about various things, or to Martin. But in fact, I learn a great deal about plastic surgery and orthopedics, and mainly it's just really good fun. They're necessarily chaotic clinics because we all wander around into each other's rooms and stuff. So it's a wonderful chaos to work in. My job at that time is really to provide some means of optimization of the patient. In any way I can. So if they've got some sort of sore or diabetic neuropathic foot or something, then I've got a pressure offload. If they're smoking or they've got other comorbidities, then I've got to work on that. But actually, the main thing that I end up doing is advising them to stop their antibiotics at least 2 weeks before they come in for operation. And that's because very few people who come to clinic have acute systemic disease and they're not unwell. So I can very safely say, stop your antibiotics, because when you come in for operation, we want to be working in an antibiotic-free zone to maximize our microbiological diagnostics. In Oxford, we do very little preoperative diagnostic sampling. I know that is probably at variance with many other places, but we'll talk about the various indications. Here we might consider it if we're thinking about an exotic infection, if someone's been traveling or someone's had an unusual injury. But in fact, those are so rare that I don't think it's frequent that that's the indication. Occasionally, the surgeon will say, I don't know whether to do a 1-stage or a 2-stage revision surgery. Can we know what the bug is before we start that? We think that biopsies and aspirates are too insensitive for this. And I'll show you some of the statistics later on of how useful a single aspirate or biopsy sample is. Sometimes surgeons want it for selecting the local antibiotic that they want to implant at the time of surgery. The marginal gain from this is that in most cases we could use empiric therapy with gentamicin, vancomycin or tobramycin or some very broad spectrum agent locally, and therefore the gain in this is really very limited. So actually the ones we most commonly use preoperative diagnostics is to guide the choice of suppressive therapy. And in this case, of course, these are patients who aren't really going for operation anyway. So it's to help us manage long-term antibiotic plans for people who probably can't or either don't want or don't have an opportunity or the health to go through a surgical procedure. Most of our diagnosis then comes from our intraoperative sampling, and we have a religious fervor about how this is done. Every patient has one of these sets opened for them very early on in their operation, and it has 5 sets of forceps and 5 gouges and 5 bottles. And we absolutely insist that wherever there is infection suspected, we will request 5 separate labeled samples. So we must know where they're from, whether they're membrane, whether they're bone, whether they're femoral head, or whether they're pus, or a wall of an abscess or something. They have to be deep. We don't use any surface swabs at all for diagnostics, or sinus swabs, because they will almost invariably be colonized with a number of pathogens, and you can't tell which is the one that's causing all the mischief. So we take 5 separate labeled deep samples, each with clean instruments, so the tips of these aren't touched even by a gloved hand. And they're sent for microbiology. And then 2 representative samples are sent for histology. The 7 samples are taken from whatever looks abnormal, and if they don't look abnormal, but you're still trying to rule out infection, you have the specific spaces from where they're taken, depending on what joint's being investigated. Now, I said I would say why a single sample probably isn't all that much use, and this is the graph that we've used to develop this protocol of 5 separate samples. So I'm going to go through the first bit first. If you take a single sample, the chance of this being a true positive is just about 60%. So you've got little more than tossing a coin as to whether that's going to give you your answer in terms of microbiological diagnosis. You can take more samples if you want, but each one just raises the sensitivity, but the specificity decreases. So you're more likely to get contaminants the more samples you take, but what we do then is we say, if 2 or more of those samples yield a phenotypically indistinguishable organism on culture, then you've clinched the diagnosis. And that's because that's going up this line here. This is 2 or more of the same. The sweet spot on this ROC curve is where sensitivity is highest, so at 1, and specificity, or the 1 minus the specificity, is lowest. So you want, this is the sweet spot here, where 1 is meeting, 1 on the y-axis is meeting 0 on the x-axis. The closest number of samples that we get to that is 5. So that's why we take 5 samples for intraoperative diagnostics. And if 2 of them grow an indistinguishable organism, we say we have clinched the diagnosis. We used to do gram stain, but we've really abandoned it because it's just not sensitive enough. We take the samples as soon as possible during surgery because the surgical wound will almost invariably become contaminated with all the manipulation of the surgeon's hands and instruments. So we really hope that the surgeon will open the infected site, retract the edges of the wound, and then take the samples. And we say that taking the samples has to be an absolute ritual. As I say, you don't touch the instruments, you don't put your fingers in the wound, you try to do everything remotely. By the end of sampling, there should be no blood on your glove, but you should have 7 deep surgical samples. Lots of us, in this country at least, fail to use histology. This is a really important part of the diagnosis, and although it can't give you very much information, it can't tell you what the bug is, and it can't tell you what the sensitivities are, it's far more accurate in distinguishing between the presence or the absence of infection. And given that about 20% of cases are in fact culture negative, it becomes a really, really important part of the diagnostic pathway. I would implore those of you that have the influence to see if you can include histology if you don't already have it. And the next thing is the surgical debridement or excision of abnormal tissue. And our surgeons are our orthopedic surgeons are very fortunate because of the backup from plastics they have. Not everybody has that privilege, but essentially they try to remove all of the dead abnormal or non-vital tissue. That might include a segmental resection. So he's cut, an inch or 2 of the tibia here. He's going to have to do some fairly clever stuff about moving bone about. In this case, there's a little bit of white tibia here. He's going to have to cut another ½ centimeter off here, I think, because that is still not bleeding. So it's non-vital tissue. So that's going to form a nidus for infection. I've put here wash gently thoroughly because a lot of people use really high pressure washers. And we're not sure that that isn't potentially seeding stuff. So I just say use lots of volume of fluid and do it gently, often from the top of the wound down rather than from the bottom of the wound. With the pressure washers, people squirt stuff at high pressure in here, and I'm worried that it might just lodge stuff further up. The dead space is very important. If you don't fill your dead space with something, blood will fill it, and that's the perfect agar plate for recovery of your germs. In Oxford, we nearly always aim for primary closure. And again, that's because of the privilege we have with having plastic surgeons. We don't use VAC dressings, for instance. I think those are very popular in some centres, but we find them of very, very limited benefit, provided we can get primary closure. And they often delay the definitive treatment rather than improve out. In order to help the ID microbiologist choose the duration, the course, and maybe the type of antibiotic we're going to use, we rely very heavily on a clear operation note. And all of our operation notes are reviewed by the physicians when the patient gets back to the ward as part of the routine care that we provide. And the sort of detail about, here it says somewhere there was a bit of a chunk of cement lying outside the femur. So this is obviously revision surgery. And he found some hidden pus. So there might be something to this. Much more helpful, he said, I can't guarantee complete resection. So we've got to think this is quite a higher than normal chance of failure, of treatment failure. So we've got to mitigate that somehow. Immediately after sampling, the patients are given very broad spectrum antibiotics. In Oxford, we use vancomycin and meropenem because if you look at a series of patients, I think it was about 150 patients, that combination covered the vast majority, irrespective of whether they'd had a history of metalwork or not, and irrespective of whether they had missing other features or whatever. So vancomycin and meropenem are the 2 antibiotics that we most commonly use. That's been backed up now by a second study, also by one of our registrars in 2019, which again shows that the lowest resistance that we have is to vancomycin and meropenem. So we're very happy that we've got that right, although it doesn't fit very well with antimicrobial stewardship because we try to limit the amount of carbapenem we use. Either way, that's what we're doing. The choice is based on local epidemiology, and it might be very different where you are. So don't just assume that those are the right antibiotics for empiric therapy. It also changes according to the risks that as we assess and the resources. So for instance, if it's a very elderly patient and we want to avoid C. diff, we might change something a little bit. And as always, they're individualized to patients in a very specific way. So if a patient's previously had something that's meropenem resistant, then we might choose to change that. Or if a patient's had 4 or 5 surgeries on that joint before, we might use daptomycin instead of vancomycin because of the risk of VRE. So everything's individualized. I put this slide really in for the surgeons because most of our samples are positive in 3 or 4 days. And that's important because there's a tendency to keep patients in for a very long time whilst the culture is complete. Usually labs will culture stuff for 10 days or even 14 days. And I don't think there's a real need to hold patients in hospital for that long until the cultures are complete. Once you've got a positive culture, and that's most commonly in the first 48 hours, you can start planning your therapy. You don't necessarily have to wait till the end of cultures. What we do here is we stop gram-negative cover if no gram-negatives are growing after 48 hours of incubation. I personally tend to use 2 agents for gram-positive organisms, rather, except for streps. And we always look at the operation note to see if we need to modify something from the surgical history or the patient's past medical history. The job of choosing the right drug also falls to us. And it's based primarily, of course, on the susceptibilities that you found on any drugs that you've managed to grow. But if we also think about the pharmacokinetics and the pharmacodynamics, we consider quite carefully the effect of stewardship and interactions with other drugs and side effects. And of course, we're conscious of costs and convenience. So this is the most important, but remember, I've already said that about 20% of our known osteomyelitics or prosthetic joint infections are culture negative. So we don't always have susceptibility to guide us. The duration of therapy is quite difficult as well, mainly because there isn't a lot of evidence. When I started as a consultant in 2009, we were quite frequently treating patients for 1 year or 2 years if they had retained metalware. And we weren't quite sure why we were doing that. That was just the habit at the time. So we did question it. And this is a really nice study that Philip Bejon and Ivor Byron led on, where in 100 odd patients who were treated by DARE, so this is where they've got retained metal, the drugs were stopped either sort of 6 months or between 6 months and 1 year or beyond 1 year. So this graph shows that about 5% fail whilst you're on antibiotics. About 15% the clock is restarted when they stop antibiotics for these lower 3 lines. And whatever way you look at it, that they end up with failing in about 15% of cases. The implication of this is that continuing antibiotics beyond 6 months just postpones failure. It doesn't reduce it per se. So there's no point in saying, oh, it's still a bit red, or it's still pussing out, or it's still got something. You know, you can't cure it. You can't improve the outcome by continuing antibiotics for a long time. There are, of course, some cases where we do continue antibiotics for a long time, and those are mainly the ones where we just want to suppress the infection. We're not expecting to cure, but we're trying to limit the amount of discharge and the amount of pain the patient has. There's another study that tried to look at determining shortest possible duration in prosthetic joint infection. This was a difficult study in Spain, a very selected group of patients on a very selected so this was only staphylococcal prosthetic joint infection managed by DARE, and it was using just 2 specific antibiotics, levofloxacin and rifampicin. And they found that in hip surgery, 8 weeks was non-inferior to 12 weeks. And that's because the confidence intervals of this don't exceed their non-inferiority margin. Unfortunately, with the knee, they weren't able to demonstrate that. So it doesn't really help us with knees. It doesn't say that we need a long time. It just says that we can't reduce it according to the data that this paper provides. Unfortunately, the study was very difficult and had to stop early because recruitment was way below what was expected. But this study is really nice. So this was about 350 patients over 5 years in 71 French centres. They treated these people. These were vertebral osteomyelitis for either 6 weeks or 12 weeks. And there was virtually no difference in cure rate at a year, whether you followed the intention to treat analysis or the per protocol analysis. So this was very good for me because it's a very clear indication that 6 weeks in the absence of metal is probably ample. There has since been a study in prosthetic joint infection that doesn't show any advantage of shortening, that shows that you can't easily shorten it. And in this one, it said that there probably was an advantage in some groups of patients to continue for 12 weeks rather than 6 weeks. So we're batting in around about the right ballpark. The conclusion from this is that it was not possible to show non-inferiority of 6 weeks. That doesn't mean to say that 6 weeks was inferior to 12 weeks, but they haven't shown that it was not. They haven't shown that it was not non-inferior. As a conservative rule of thumb, I would suggest that for curative surgery, such as amputation, you don't need any post-operative antibiotics. If you've got a confident resection and there's no metal, I normally give 4 to 6 weeks worth. If you've got retained metal and it's a joint plate or a hip, then we normally give 6 weeks. For knees, we normally give 24 weeks. For suppressive therapy, you can decide yourself, what the likely benefit is. At some stage, we take most patients off suppressive therapy. Next, we've got to talk about the route of administration of our antibiotics. And there was a long series of papers. There was 3 in total in this particular magazine issue of the New England Journal. They said to treat osteomyelitis, you need prolonged parenteral high-dose antibiotics. And we challenged this with a study called the Oviva Study, where we were comparing tablets with injections, so oral versus IV. That's what this stands for, oral versus IV antibiotics. And we were recruiting anyone that would ordinarily get 6 weeks or more of antibiotics. The patient had to be randomized within 7 days to one arm or the other from the date of their surgery. And we followed them up to a year looking for definitive treatment failure as our primary endpoint. So this was a very nice Kaplan-Meier graph. And when you're doing a non-inferiority study, this is exactly the sort of negative result you want to find. So in the dotted line was the Kaplan or the survival graph for oral therapy, and in the solid line, survival graph for IV therapy. The fact that there looks like no difference is very reassuring, and we can conclude, even if you look at the numbers, that in intention to treat, it's around about 13 or 14%, and in per protocol, it's around about 13 to 15%. So our conclusion then was that oral therapy is non-inferior to IV therapy when used for the first 6 weeks in bone and joint infection. This happens to be my family and 2 of the 3 of my research colleagues trying to spell the word Oviva. I try and sneak it into most of my talks. The fact that there is non-inferiority of oral therapy is really good for practice. It helps with our antimicrobial stewardship. And of course, it absolutely eliminates virtually all worries about line infections. It saves quite a lot of money. We think in the UK, it might be up to £30 million a year in the UK, and in the US, just on joints, just on hip and knee joints, maybe 140 million. And of course, the main beneficiaries are that the patients can get home earlier. It's far more convenient for them that they don't have to wait indoors, waiting for a nurse to come and squirt some antibiotic into their PICC line. And it provides them with a sense of ownership of their own treatment. So the next thing is to ask about local antibiotics. There's increasingly we're squirting in some sort of polyfiller stuff or some beads that contain antibiotics. And that's becoming not quite universal, but very close to it. The advantage of local antibiotics is that you've got a very high concentration at the site of the infection, 100 or 1,000 times that you can get through systemic therapy. And that's mainly because, of course, if you give very, very high systemic therapy, you get lots of side effects and toxicity, and you knacker people's kidneys or liver or whatever it is. So these are the two main advantages, that you get a very high local concentration with very limited toxicity. There is precedent for that in Sheffield, not very far from where I am at the moment. They frequently use very limited courses of systemic therapy, but they haven't yet done a prospective trial, so they haven't managed to persuade everybody that it's a reasonable option. But we use this paper to demonstrate that it is used, and therefore there is sort of equipoise. When they looked at 114 consecutive two-stage revisions for a hip, they got about a 13% failure rate. You'll remember 2 slides back, I said in the Oviva trial, that was our overall failure rate for IV or oral. So we're batting again in the right ballpark. There's another small case series of 13 complicated cases. So these are all at least second-time surgery in the Lebanon, who were treated with just 2 or 3 days of systemic antibiotics, but all of them had local antibiotics and all of them had a favorable outcome. So what we need then is a prospective randomized control study with appropriate health economic evaluation and monitoring with appropriate governance. And that's what we've done now. It's called the Solario trial. In this, patients are allowed systemic therapy for up to 7 days after their operation. All patients have local antibiotics. And within that 7-day period, they have to be randomized to either stopping their systemic therapy or continuing their systemic therapy for whatever is their standard of care. We've got a number of sites in the UK open and one in Portugal. We're opening sites elsewhere in the UK, and these 4 in mainland Europe. Our recruitment's all right. This was the big hammer of the pandemic where we almost stopped recruiting entirely. And we need 500 patients. We're roughly at 275 at the moment. So I'm afraid I'm blinded, so I can't give you any interim results, but we were told by our data monitoring safety committee that it is safe to continue. So I presume there's nothing really, really nasty in the offing. Just for any surgeons that might be looking at this, this is the type of antibiotic, local antibiotic that can be used. Some of these are PMMA, so these are spacers with antibiotics mixed in with them. These are carriers that can be molded, and there are some biodegradable antibiotic carriers as well. So there's lots on the market that are available. We've used 11 different antibiotic carriers in our trial so far. So this is the team this is a genuine photograph of a ward round. And this is the team that does all of the work. It's a very, very horizontal structure. Nobody has more or less ownership of the patients. And all of us believe and in fact do provide great value. This guy is our orthopedic registrar. He loves his coffee. Otherwise, they've all got good jobs and a specific point to impart to the care of our patients. It's through doing this that we've developed some very nice figures that have very recently been published. Just in this year. These data, I must tell you, were extracted by a professional data mining company from a national database called HES. So I was not involved in selecting these data or in writing up this paper at all, but it tells us that we think we're we're treading along the right road. This paper looked at 25,000 cases of osteomyelitis that were managed surgically. And they were divided into 3 groups: the bone infection unit where we work, the rest of England, and the subgroup of that was the top 10 in terms of top 10 numerically sized trusts after us. So these are the 10 sites that do most operations for osteomyelitis after us. And the first thing to say is that our amputation rate was around 6% as compared to 13 or 16% in the other groups, which we think is probably a reasonable measure. And this is, I think, especially impressive because we do take tertiary referrals. So we often have patients that have been operated on multiple times at other centres. What was surprising is that there's a mortality advantage as well. I think we have, I can't quite see the side of my slide, but I think we have a 4 or 5% mortality as opposed to a 20% mortality. Interestingly, in these, the commonest cause of death as recorded on the death certificate is sepsis. In ours, the commonest ones are myocardial infarction, stroke, pneumonia, and something else. I can't remember, but sepsis for us, or bone and joint infection, is way down the list at number 8. So we think we're treating infection well, and as a result, our patients benefit. And they benefit not only because of their survival, they also get out of hospital earlier, despite the complexity of the treatment that we offer. They tend to go back to theatre less frequently than the other groups. And our primary amputation rate is actually smaller. So we're not saving the salvageable limbs we're not polishing our numbers by amputating less complicated cases. The final thing is that going back to theatre for admission in 2 years is less common in the Oxford group than in the non-Oxford groups here. It actually flattens out as you get towards 18 months, but overall at 2 years, the average number of admissions is lower in the tertiary treatment. So we think that multidisciplinary team tertiary care saves limbs, lives, and money. And we needed to prove this because we are an expensive unit, partly because of the way care is remunerated here. So we get the tariff from the government for doing a total knee replacement is exactly the same for a primary as it is for a complex secondary 2-stage. And very often, you know, we've got patients who are in hospital for a very long time because of the amount of plastic. So there's no uplift for plastic surgery. And that's why we're expensive. So actually we're a loss-losing unit within our hospital trust. But overall, I think we're saving the health economy absolutely tons of money. In the end, of course, we have many, many variables that I've talked about today. The very central one, of course, is the patient, and they're always involved in our decision making. But if we want to do the best we can and provide the best outcome for our patient, it all depends very much on the right teamwork. I hope you've enjoyed this presentation. I'm very happy to take questions.
Thank you, Dr. Scarborough. That was very informative. Are there any questions? You can just open your mic up and ask directly or put a question in chat. I was wondering, has there been any change in your practice during the pandemic in terms of pushing the patients out to out of the hospital unit to be treated at home?
No, there hasn't. The biggest impact the pandemic had on us actually was diversion of our staff away from the elective sites, and we are an elective hospital, this orthopedic hospital, and lots of our staff were pushed out of the elective site into the acute site, and that's why our operating stopped essentially. But in fact, the whole of the Nuffield Orthopedic Centre where I work was classified as the green site. So people had to have a COVID test 72 hours before they were admitted and on the day they were admitted. And we tried to keep the whole of our hospital green. And that meant that we were able to restart elective surgery, including cataracts and other things that we wouldn't normally operate on in an orthopedic hospital, but we could restart that earlier than other centres could. So we became a multi-specialty hospital for a little while because we were deemed to be the safe place within our trust. We're not geographically, we're probably about half a mile from the other 2 hospitals in Oxford, which are part of the same organisation. Yeah.
I see. That's interesting. So you're back to being an orthopedic subspecialty hospital now, or
we still have some eyes in our hospital, but
well, maybe you can get a combination.
Yeah, exactly. Yeah.
a knee and a cataract.
At the same time, that would be brilliant, wouldn't it?
That would be great. In fact, simultaneously.
Yeah. Yes. Yeah.
Are there any other questions? Going once, going twice. Okay. Well, thank you so much for being so flexible and willing to accommodate us with this wonderful lecture. It's
Not at all, no trouble. Yeah.
nice meeting you.
Good.
Thanks very much, Dr.
Excellent.
Scarborough. Thank you.
No
Cheers,
problem.
man.
Bye-bye.
One thing sector.